So now we're going to do another one, a very similar situation, but some aspects of it are different to drive home some different ideas amongst. Now we have a 30-year-old who presented with a reported self-inflicted gunshot wound to the head. One little piece of advice here, you as the clinician will be given reports by family, by EMS, by police when patients like this come into the emergency room, and when you see patients sort of in the heat of the moment. I would encourage you to not get too fixated on whether it was a self-inflicted or whether someone was inflicted by another person, because the details are sometimes very vague, and what you put in the chart has significant impact on a lot of factors, particularly medical legally. So just sort of state the facts as you know them, and try not to get into the drama of what happened. He was found outside by the family in the woods. When he arrived, he was a GCS of 2T. So if you notice here that we didn't give the 1 for the T, his motor was 1, eyes were 1, and verbal was he was intubated. So he was not doing anything on exam, not opening his eyes, not moving his extremities. He does not open eyes, does not follow commands. His pupils are 6 millimeters bilaterally and non-reactive, meaning that would be what someone might call fixed and dilated. No corneal, no cough, no gag. These are brainstem reflexes that were tested. So if you stimulate his cornea, he does not blink. If you stimulate the back of his throat or his trachea, he does not cough. If you stimulate the back of his throat, he does not gag. And then when you stimulate his extremities, there's no movement to stimulation. So this is the initial CAT scan. The top left is an axial non-contrasted head CT. The bottom left is an axial non-contrasted head CT, and then the right is a non-contrasted head CT. And so what we see here are multiple areas of hyperdensity within the brain. There has been a disruptive trajectory through the middle of the brain, crossing what we call the center aspects of the brain, and blood products inside the ventricles. And then on the top left, I want you to notice that there's the normal gyri that we see on a normal CAT scan have been obliterated. So there's tremendous amount of cerebral edema, and the brain has swollen, and so those normal sulci that you see on a typical CAT scan have been obliterated because everything is essentially smashed together very tightly. And so the question becomes, is the patient brain dead? And that's a very important question to understand, because there are implications for the next steps in this person's treatment that will be dictated whether on this fact. So again, his GCS is 2T, does not open eyes, does not follow commands. His pupils are 6 and non-reactive. There's no corneal, no cough, no gag, no movement to stimulation. So are we able to say that he's brain dead? Well, not quite yet. So you need more information. So his blood pressure is 75/40, which is not normal, and his temperature is 35 degrees Celsius, which again is not normal. So the short answer is no, in that to consider someone brain dead, there's very specific clinical criteria that you must have evaluated before making that determination, because brain death is a diagnosis of death. So a person's heart, lungs can still function, but once they're declared brain dead, then they, for all legal purposes, are deceased. And that has a lot of weight and impact in what we do for these patients. So practical guidance for determining a person's brain death. So the clinical evaluation. So you need to establish an irreversible and proximate cause of coma. So the cause of coma is is established with history, examination, neuroimaging, and it's not, again, it gets down to the specifics of what has the patient been given, what drugs has the patient received to be intubated, what sedative meds has the patient been given, is the patient intoxicated, are they on any illicit drugs. So all of these have impact on whether you can describe someone brain dead or not. The electrolyte acid-base balance, endocrine disturbances, are they acidotic? Are there things that can be corrected to normal physiologic levels that allow us to say this person's lack of a neurological exam is not being caused by the fact that they're severely acidotic. It's not being caused because they're intoxicated. It's not being caused because they've been paralyzed with a neuromuscular blocking. We need to clearly define each one of these before saying someone is brain dead. They need to have a normal temperature. Patients who have severe traumatic brain injury very often have very difficult ability in maintaining normal temperature, and so we have to warm them up, give them warming blankets, give them warm saline to get their core temperature to greater than 36 degrees Celsius. They need to have normal systolic blood pressure. And sometimes this is not achievable. Patients who have neurotrauma very often also have other traumas that prevent us from obtaining a normal systolic blood pressure. So I have been in the situation on a number of occasions where the trauma surgeons are asking me, is this person brain dead, because they have abdominal injuries, and I can give them guidance to say, well, this person does not appear to have a survivable injury, but I can't say that they're brain dead, and need to be very careful about making that determination before they say, okay, we're not going to take this patient to surgery to treat their splenic laceration. And then they need to have, a very well-defined neurological exam. And that exam most often is best done by two separate examinations and two separate examiners that have a clear understanding of the neurological exam and what it means to be brain dead. Hospitals tend to have their own individual policies about who can do this and who's qualified to declare someone brain dead. In general, it's not the intern on the neurosurgery service. So their clinical evaluation, so their coma, so they must have no evidence of response. They cannot open their eyes, no movement to noxious stimuli. They must have absent brain reflexes, so no pupillary response to light. Absent oculomotor reflexes using oculocephalic testing. That's where we rotate the head back and forth, and then also we do what we call cold calorics, where we inject cold saline into the patient's ears that will induce a nystagmus if the patient has brainstem reflexes. If both of these are absent, then their oculocephalic and oculovestibular testing is absent. And then absent corneal reflex, that's where we stimulate the cornea, and that should prompt a blink response in a patient with an intact corneal reflex, but in a patient who is brain dead, that will be absent. No movement in their facial muscle to noxious stimuli, and then no movement to their with tracheal or pharyngeal stimulation as well. And then there's apnea testing. And so apnea tends to be the last thing we test. We've established that they have no underlying cause that is causing them to be comatose, like drugs or temperature or blood pressure or electrolyte abnormality. We establish that they have no movement to noxious stimuli, they have no brainstem reflexes, and then we test their apnea, meaning that they have no ability to have a breath drive. And that's a very hard, that's one of the last things to go in terms of the brain death. And so if you have an absence in breathing, then very likely that you are brain dead. It's called a CO2 challenge, where we remove the patient from a ventilator, and then we watch for spontaneous movement of breath, and then we measure their blood CO2 levels to see how high their carbon dioxide levels have gotten. And if it is high carbon dioxide and no breath movement, then they're apneic. And when you hold your breath, the thing that causes you to want to breathe is not your need for oxygen, but actually your need to get rid of your CO2. And so when your CO2 goes up and you don't breathe, we consider that to be apneic. So, just to clarify, a person needs to be normotensive, they need to have normothermia, euvolemic, eucapnic, so their CO2 needs to be in that 35 to 45 millimeters of mercury range, not be hypoxic, and no evidence of CO2 retention, COPD, severe obesity when determining these things. And then once all of these things are established, then we can just say, okay, we have done everything we can do to assess someone's ability to have a response, and we've not been able to distinguish it. We have repeated this test over time and it has remained constant. Then we can make the determination of brain death.